Welcome to the lecture on surgical principles. This lecture will review obstetric surgical principles that we ought to follow during operative delivery, particularly in a mother delivering by cesarean section. Before considering an operative delivery, you must obtain a detailed medical history and perform a thorough physical examination to assess the patient's overall health status and identify any risk factors or comorbidities that may affect the surgical outcome. In particular, you want to know if the patient has any signs of infection, any history of bleeding conditions or clotting disorders, or any medical conditions that could be affected by anesthetic procedures. You also want to know if they have had any prior surgeries or blood transfusions or any drug allergies. An obstetric history should include assessment for any complications in this pregnancy, any fetal concerns, and the placenta position. Once you have obtained your history and completed your exam, you want to ensure you have informed consent to perform a procedure. The patient should understand the procedure and any potential complications. Lastly, you need to collect lab work prior to surgery, including a complete blood count, coagulation panel, and a blood cross-match. Other specific lab tests may be indicated based on the patient's medical history, such as liver function tests or renal function tests. As you are preparing the patient for surgery, you also need to prepare your team. Obstetric surgery requires multiple teams, including the obstetric team, the anesthesia team, the nursing team, and the pediatric team. The surgical team should consist of a surgeon or an obstetrician, anesthesiologist, and scrub nurse or assistant. You may also consider having a pediatrician nearby if available for newborn assessment. Open communication within the surgical team is essential to foster a collaborative environment that prioritizes patient safety. The surgical environment is very important and requires a lot of equipment to be effective. Good lighting is a critical component in the operating room during a cesarean delivery. Continuous monitoring of maternal vital signs throughout the procedure is required, and fetal heart rate should be assessed prior to starting surgery itself. Regional anesthesia, spinal or epidural, is preferred for non-emergency cesarean deliveries due to its benefits in reducing blood loss and allowing the mother to be awake during the procedure and bond with the newborn. However, general anesthetic equipment should be available in case of an emergency. Ensure that all instruments are sterile and that a sterile field is established to minimize infection risk. Use appropriate drapes to cover the patient while exposing only the surgical area. The patient needs to be correctly positioned. Current guidelines recommend a 15 degrees left lateral tilt during cesarean delivery to prevent aortocaval compression. While some studies have shown that the supine position does not significantly impair neonatal acid-base status when maternal blood pressure is maintained, it is still associated with risks of hypotension due to aortocaval compression. Once the patient is positioned and prepared in a sterile manner and anesthesia confirmed, the procedure can start. It is recommended to perform a transverse skin incision approximately 2 cm above the pubic bone. This is called a Pfannenstiel skin incision. Once the skin is incised, the abdominal soft tissue layers and rectus muscles can be separated with sharp or blunt dissection to expose the lower segment of the uterus. Once you have made it through the abdominal layers to the uterus, you have to decide the type of uterine incision to make. You should already have a plan for the uterine incision based on the situation, emergency or elective C-section, medical history, and gestational age. The choice of uterine incision during cesarean delivery is crucial as it impacts surgical access, recovery, and cosmetic outcomes. The standard low-segment transverse incision accounts for 90% of all uterine incisions. It is commonly used for elective cesarean deliveries and in cases where optimal access to the lower uterine segment is needed. It is associated with lower postoperative pain and better cosmetic results. However, in some circumstances a nigh transverse or midline, also called classical, incision may be indicated. Considerations for choosing an incision depends on several factors, including maternal body habitus, previous surgical history, and specific indications for cesarean delivery like breech presentation and multiple gestations. Physician experience may also affect the incision type. The surgeon's familiarity with specific techniques can influence incision choice. In urgent cases, speed may take precedence over cosmetic considerations, leading to a preference for vertical incisions. Understanding the different types of incisions helps in selecting the appropriate technique based on individual patient circumstances. Classical incisions are often used in early gestations as the lower uterine segment is not well developed. The T&J incisions can be used in emergency circumstances when there is difficulty extracting the fetus from the uterus and the surgeon needs more room. Once the fetus is delivered, the placenta needs to be delivered. Administering oxytocin will aid in placenta delivery, help reduce uterine bleeding and promote uterine contractions. Once the placenta is delivered, a thorough examination of the uterine cavity is essential to prevent complications like retained products of conception. We will now review over the next few slides the instruments that are used to perform a C-section. The type of surgical instrument we use differs for the different tissue types and steps of the C-section procedure. The successful execution of a cesarean delivery relies heavily on the appropriate selection and use of surgical instruments. Each instrument serves a specific purpose during different stages of the procedure, from skin incision to closure. You want to make sure you are using gentler instruments on delicate tissue such as forceps with no teeth on peritoneum, whereas on the tougher tissue like the fascia-toothed forceps are more appropriate. In cesarean delivery, the use of forceps with teeth is crucial for manipulating and grasping skin and fascia effectively. These instruments provide a secure grip, which is essential for ensuring precision during surgical procedures. Some examples include Ramsay and Bonney forceps. During a cesarean delivery, accessing the peritoneum is a critical step that requires careful handling of tissues. Forceps without teeth are specifically designed for this purpose, providing a gentle yet secure grip on delicate tissues. An example of a non-toothed forceps is a DeBakey forceps. During a cesarean delivery, managing blood vessels effectively is crucial for minimizing blood loss and ensuring patient safety. Clamps without teeth, artery forceps, are specialized instruments designed to occlude blood vessels gently without causing significant trauma. We call them homeostatic forceps. A Kelly clamp, which is shown on the right of the slide, is a commonly used clamp with a straight or curved design, suitable for occluding larger blood vessels. A mosquito clamp is smaller blood vessel clamp and used for finer vessels. Its smooth jaws allow for precise control during vascular manipulation. Bleeding is the most common complication during cesarean section. Excellent surgical technique and timely intervention as well as pre-operative planning will help reduce the risk of significant intraoperative bleeding. Management of placenta delivery, as discussed with uterotonics, will also help reduce bleeding. If heavy bleeding is noted, there are 250 microgram steps to take to manage the bleed. As mentioned, uterotonics should be the first-line medication for uterine bleeding, as tone is often a component of heavy bleeding at the time of C-section. The most effective and safest of these is oxytocin or carbetocin. Ergometrin is effective but can lead to hypertension and coronary artery spasm. Oxytocin can be administered either IM or I5. If you are administering oxytocin IM, it should be in a 5 to 10 international unit dose. If you are administering a rapid I5 dose, it should be 3 international units. Oxytocin can also be administered in an infusion of 20 to 40 international units per liter at a rate of 7 to 15 international units per hour. Carbetocin can also be used as a common first-line uterotonic. It is more commonly used at the time of C-section in a dose of 100 micrograms I5 over 30 seconds to 1 minute. Other second-line uterotonics include ergometrin, carboprost, and tranexamic acid. Ergometrin, commonly called Ergot, is administered in a 250 microgram dose. IM Ergot is contraindicated in patients with hypertension. Carboprost, commonly called Hemabate, is also administered in a 250 microgram dose. IM Hemabate is contraindicated in patients with asthma. In addition to medication, uterine massage should be performed. If bleeding continued despite medications and uterine massage, an intrauterine balloon tamponade can be placed. This involves placing a balloon catheter inside the uterus and inflating it to apply pressure against the uterine walls, which will compress blood vessels and control bleeding. It can also be a temporary measure while preparing for more definitive interventions. Other techniques to control bleeding include uterine compression sutures such as A.B. Lynch suture demonstrated in the diagram on the left. Alternatively, uterine artery and/or internal iliac artery ligation can be performed. Artery ligation refers to the surgical procedure of tying off an artery to reduce blood flow to the uterus and thus decrease bleeding. The diagram on the right depicts arrows that point towards the areas of possible ligation of the uterine artery. If internal iliac artery ligation is performed rather than uterine artery ligation, the artery should be ligated 2 cm from the bifurcation of the iliac artery. This should be performed bilaterally but can be done on one side only. Lastly, hysterectomy, which is surgical removal of the uterus, is the last resort in cases where bleeding cannot be controlled by other means. While this is the most definitive solution, it is also the most invasive and has significant risks associated and implications for future fertility. We will now discuss the risk of infection at the time of C-section. Infection is a common complication of C-section, particularly in immunocompromised or obese patients. Infection can be transmitted in many ways, such as on equipment, patient environment, or medical staff. All bodily fluids including blood, urine, vomit, and sputum should be considered infectious. To reduce the risk of infection, we should follow standard antiseptic technique. Antiseptic technique involves proper personal protective equipment for healthcare provides, proper preparation and draping for surgical patients, the use of sterile instruments, and the proper handling and disposal of equipment and biomedical waste. The use of prophylactic antibiotics at the time of C-section also significantly reduces the risk of a post-operative infection. Antibiotics should be administered within 60 minutes of the skin incision at every C-section. At any surgery, there is risk of injury to surrounding organs. At the time of C-section, the organs at risk of injury include the bladder, the bowels, and the ureters. The risk of organ injury is slightly increased in patients with a history of multiple cesarean deliveries or other abdominal surgeries, as there are often pelvic adhesions that complicate the difficulty of the procedure. Patients who have had multiple C-sections or abdominal surgeries are also at increased risk of abnormally adherent placenta, which can also complicate the procedure and increase the risk of adjacent organ injury. Obstetric history and preoperative risk assessment is essential to prepare for a difficult procedure and manage any injuries accordingly. Immediate recognition and repair of any organ injuries will lead to better outcomes. In the first hour after an uncomplicated cesarean section, the patient should be monitored closely in a recovery area where urine output and vital signs can be closely monitored. You want to be monitoring from signs of bleeding in particularly as delayed PPH as possible. If the patient remains stable, they may then be transferred to the postpartum ward. Patients should be encouraged to start breastfeeding if desired, skin to skin, and mobilizing as soon as possible. Within 24 hours, the patient should be walking and eating and drinking a normal diet. Successful cesarean delivery requires meticulous preparation, appropriate equipment, and coordinated teamwork. By following these surgical principles and implementing evidence-based practices, healthcare providers can optimize patient outcomes and minimize the risk of complications associated with cesarean delivery. Thus, we must emphasize the importance of thorough training in surgical techniques, instrument handling, and ongoing education on handling potential complications related to cesarean deliveries.